the one question that keeps coming up, and I'm glad that we have Dr. Sen in there, because that's what she does in her lab, is question for small cell transformation from the non-small cell lung cancer. Should the molecular testing be done after histological testing? I've been told by my oncologist, since there are no targeted therapies available in Poland, this question is originating from Poland, there is no sense to do that. And it's a pretty controversial question, to be honest with you. And I'll start with Dr. Sen, and then maybe if the other panelists can chime in as well.
Yeah, just to orient everyone, small cell transformation is when either an EGFR, ALK, and now even we are seeing with KRAS, when these patients get treated with the tyrosine kinase inhibitor for that oncogene, so for EGFR, it would be osimertinib. When they get treated and they develop resistance, they actually transform to small cell lung cancer. And it's right, because when the disease comes back as small cell lung cancer, most often, I think in almost all cases, the EGFR mutation will still be retained, right? We will still have the EGFR mutation, along with, in most cases, we see RB1 and P53 alterations as well. So yes, once you have histological transformation, I think molecular testing, we don't have ways to treat it because they're treated like small cell lung cancer at that point, right? They're treated with chemotherapy and other things which would be a treatment for small cell lung cancer. So in that case, apart from the mutation, which is EGFR or ALK, which is still retained, molecular testing, still we don't have anything to do with that information because we don't have targeted therapies that can go for that cancer type. So I think till now, molecular testing for that percentage of patients could be not actionable at this point. And I see another question, which is to do with the same thing. For small cell transformation, should TKI be kept going along with chemo? So, when we did the testing in our clinical samples, we saw EGFR mutation was still retained. So in my opinion, you would still have to keep the pressure on the EGFR to get the best. So I would say, if it's an EGFR mutant patient, then having osimertinib in the mix would actually help because that helps control the EGFR part. And then you come in with a combination, which is to treat the small cell lung cancer tumor.
Yeah, thank you.
I completely agree, is the short answer.
Good.